Thank you so much, Dr. Win. Good morning to you all here, and also to our colleagues who are watching this session and the symposium virtually. We know we have made a lot of progress on the viral hepatitis front over the past decade. We have been able to get high rates of cure, specifically for hepatitis, with lesser toxicity and also with the lesser duration of drugs. But we haven't really been able to get onto that when it comes to hepatitis B. So today I'm going to talk to you about some of the progress that we have achieved so far, and also in terms of some of the gaps that we still have. It's good to always remind ourselves, we know there are numbers behind, there are estimated figures, data that comes out, which always guides us in terms of devising our own policies, and also, national programs to respond and achieve targets that has been agreed on as a global commitment. So we know, just to revisit some of this number, I'm sure you all are well aware of this, but let's go through this one more time. 58 million people living with chronic hepatitis C globally. 34% of these are in our region, in Asia Pacific. 30% of the new 1.5 million infections are in Asia Pacific, and we bear around 39% of the global mortality. This is specifically on hepatitis C. So we see that the estimates that we have, both in terms of the disease and in terms of mortality, we have quite a huge burden and responses that is required. As a global community, we have agreed on eliminating viral hepatitis by 2030, and two of the big indicators that we have are in terms of new cases, which is around 90% reduction, and reduction in mortality of 65%. That's what the global community has agreed on, to eliminate viral hepatitis by 2030. For this, two things that's really important is to diagnose 90% of those people with chronic hepatitis C infection, and also provide 80% of those with chronic infection with treatment. So that's what we are aiming to achieve and to provide in our regions or in our countries to achieve the elimination targets. Now, where are we in terms of the cascade? This is from the last global report that we have. Against what I have mentioned in my earlier slide, what we're looking at is a global diagnosed rate of around 21%, with 13% of those treated. If we focus it down, we have two WHO regions here, the Western Pacific region and the Southeast Asia Pacific region. The Western Pacific has diagnosed approximately 25% of the patient population and treated around 10%. Whereas the Southeast Asia region reported a lower one, around 7% of those diagnosed, of the total population diagnosed, and around 5% of those treated for the infection. So this is not, as you would see, this is not very close to knowing that we are almost there in terms of reaching the elimination targets by 2030 in the sense of the timeline, but we haven't really been able to pick this up. Now, to be able to diagnose and treat, one of the things that we need is medications. And as I mentioned earlier, we have very good quality assured DAAs for hepatitis C that can cure people up to approximately 95–97%, depending on the patient population. And we have this already in most of the countries here, at least in this room, and also outside, including Africa and Latin America. I have shown here some of the DAAs that are being used in our region, but then overall, if we look at some of the combination of sofosbuvir and daclatasvir and sofosbuvir and velpatasvir, you would note that most of the countries in our region are getting it approximately lower than $100 or $90, for a 12-week treatment course. So WHO has identified 3 regimens as pan-genotypic regimen, which means it could treat all genotypes, all the 6 genotypes of hepatitis C, and of which sofosbuvir in combination with daclatasphere is one of the combination, which, as I have shown in the slide, is being procured less than $100 for a treatment course in our region, bearing $2 in Myanmar. But then if we look at Rwanda, which is doing a great amount of work on responding to hepatitis C in Africa, they're getting it at $58 for a 12 weeks treatment. So this is the same supplier, this is the same medication, this is the same production site. So African countries are getting far more lesser in terms of the cost of these drugs compared to the cost that we are paying. No doubt we have been able to achieve quite a substantial reduction, but this is where we stand. So sofosbuvir and velpatasvir, that's another drug that is available, and that's reported to be around 178 USD for global fund related procurements. So that's where we are in terms of the pricing. There is another combination which is called as glesaprevir pirentasvir. That's also a pan-genotypic regimen that can treat people at 8 weeks, not 12 weeks compared to those other two that I mentioned, regimens earlier, but that is not available at this point as generic version. WHO has launched an expression of interest to the generic suppliers in October, so we should expect generic entry of that, if all goes well, by next 6 to 12 months. So national progresses on hepatitis C has been made. So I'm just trying to cite some examples here of some countries with high burden or sort of a national response in our region. So India has this ongoing program from 2018 onwards. Actual implementation started in 2019. Provides hepatitis C free diagnosis and treatment to all patient population. Uses this pan-genotypic regimen, and they chose to use two combinations, sofosbuvir and daclatasphere for non-cirrhotic patients, and sofosbuvir and velpatasvir for cirrhotic patients. So there's a clear distinction of which regimen to use for the kind of patient population depending on the fibrosis stage. They have reported to be having a coverage of approximately 94% of all the districts in the country. They have screened around 30 million people, of which 120,000 people have been treated so far. But the country has an estimation of approximately 6 to 12 million people chronically living with hepatitis C. So if you look at from 2019 to 2022, with 120,000 people with the denominator of 6 to 12 million, I leave it to you to decide or to make our own assessment on where we would be in the next 8 years, or how much of progress they're going to, scaling up they would be needing. Malaysia is another example. As you know, Malaysia issued a compulsory license on sofosbuvir in 2017. From that time onwards, they have been able to decentralize services. The focus has been mainly on decentralization of services, task shifting to non-specialists for the treatment, optimizing of available primary care centers to provide their services. They're also promoting self-testing. I think Malaysia is the only country that's kind of promoting self-testing in the region for hepatitis C, although we have seen that quite substantially for HIV. And they also use DAAs for treatments, sofosbuvir and daclatasphere, and sofosbuvir and velpatasvir. They also use a combination of sofosbuvir and ravidasvir, but that was not what was cited. But that's also in the pipeline for Malaysia, and that's something which is recommended for people with HIV co-infection. They have reported to have treated around 12,000 people, and also again, the denominator is around 380,000 people chronically living with hepatitis C in Malaysia. Thailand, again, has been one of the leading countries to respond to hepatitis C, started the program for treatment under a universal health coverage program in 2012. 2018, Thailand included direct-acting antivirals in our program. with sofosbuvir, ledipasvir, and sofosbuvir, but those were not pan-genotypic. But in 2021, we introduced sof and velpatasvir, which is a pan-genotypic regimen. In 2022, recently, we removed all restrictions on pre-treatment requirements, which was related to viral load, prescriber eligibility in terms of a trained internist or a gastroenterologist or a hepatologist, and extended the eligibility criteria by age, and also alcohol and drug use as a criteria for limitation was removed. We have an estimation of around 360,000 people living with hepatitis C. Also to note that quality assured pan-genotypic sofosbuvir and daclatasvir is also approved now in Thailand. I think this was in November of 2022. So as and when this daclatasvir is listed in the National Essential Medicine list, that would be another regimen which would be available for our national program. Now, whether or not we are able to get at that similar price of lesser than $100 like Cambodia or Nepal or Myanmar at $102, that's something for us to see. But this regimen is going to be available for our national program in the short time to come. We also have had community-led models. We, as Treat Asia, supported this with one of our community partners, where we tested and treated people who inject drugs in drug treatment facilities on the same day. So this is something which we have seen in HIV, but we did this in hepatitis C also. We saw a treatment response rate of around 88%. And we worked completely with the community, people who inject drugs, groups, to actually provide the screening, and also the treatment with support from medical prescribers. It took us around 6 hours and 49 minutes as a median time to start from the counseling or pre-treatment till the medicine is made available. We know that this 6 hours could be reduced to 4 hours, but that's a discussion altogether. But what we recorded in our study was around 6 hours, 49 minutes as a median time from patient entering the counseling, pre-treatment pre-screening counseling to the treatment availability. There is also C-free trial, which is happening at the moment in Thailand. And they provide treatment for hepatitis C, B, and also refer patients with HIV and hepatitis B to the national treatment program. It chooses to use sofosbuvir and velpatasvir across all patient groups, and these are the treatment sites are embedded in drop-in center run by community organizations. Now, let's look at hepatitis B. So hepatitis C, we have seen some results, and those are some promising results. Of course, we need to scale up. We have to do more, but then where are we in terms of hepatitis B? We know that there are 26 million people. I've shown some of the infections here that we commonly work on, including HIV and hepatitis C, to give you an idea of where we are in terms of comparing that with hepatitis B. So we have 296 million people globally living with hepatitis B. 59% of this patient population is in the Asia Pacific. If we look at the global cascade, we have much talked about 1990 and the 95. So we have been able to diagnose 85% of HIV population. But when it comes to hepatitis B, so far, we have been able to diagnose only 10% globally of the patient population of that 296 million, and only 2% have been treated. If we come down to Asia Pacific, it's all the more minuscule. I mean, this is like Western Pacific has treated hardly 5% of the patient population, in Southeast Asia region, which includes Thailand, India, which has large hepatitis B population. Indonesia have diagnosed only 2% and treated 0.2% of the patient population. That's very, very low if you all could look at that denominator of 296 a million. Mortality, again, 79% of this is of the death attributed to hepatitis B is in Asia Pacific. TDF, tenofovir, is something which is recommended for the treatment of hepatitis B. Tenofovir alafenamide is also now recommended on certain national guidelines based on the patient population and certain comorbidities that they have. It costs approximately, TDF I'm talking about, is around $28 per person per year. It's no longer on patent anywhere in the world. It's widely available in quality assured as a generic product. Now, we know that a lot of people are dying. Around 820,000 people die from hepatitis B globally, annually. And as I say, 650,000 or 79% is in Asia. Now, if we take HIV as an example, from 2004 onwards, which is if we look back, most of our treatment programs actually started, we have recorded a decline of around 68% on mortality. If we have a 2% global treatment on hepatitis B, is that lack of treatment actually contributing to those deaths? People are not getting the treatment when these medications are available everywhere, and it costs around $28 per person per year. So that's what I wanted to pose here as a question to you all, that, is it something that we could reflect on? The lack of treatment is actually contributing to that. I'll come to why is that lack of treatment later on. So the global commitment, there are some opportunities and challenges that I wanted to cite on. The global commitment is there, as I cited earlier, to eliminate viral hepatitis. We all as countries have agreed to achieving this by 2030. WHO has been developing and updating the guidances for hepatitis B and also for C. Hepatitis B is right now in the process of updation, and we could expect a new updated guidelines by October of this year. National programs are beginning, which was not there at least 4 or 5 years ago. Antiviral prophylaxis for prevention, Thailand and Cambodia have played a big role in this. For prevention of vertical transmission for hepatitis B is there. WHO has given out its recommendations. Many of the countries have not been implementing this, but then that recommendation is there. We also have wide availability of quality assured generic medicines, and we have the preventive hepatitis B vaccine, which has been available for quite a number of years, and that cost approximately 30 cents per dose. So you're talking about a 3 dose of less than $1. When it comes to specific challenges, diagnostics algorithms, specifically for hepatitis B, has been a very challenging and a difficult one for low-income countries to follow. That's why WHO is relooking at its guidelines again now. There has also been low awareness among patients because it's a very slow disease unless you have some sort of extra hepatic manifestations or you have other comorbidities, or you go to check for employment-related requirements. You don't really get to test hepatitis B or hepatitis C. So there has been a very low awareness among patients. There is a high and increasing rate of mortalities. This is all the more true for hepatitis B. If time permits, we could actually look at the rate of increase of hepatocellular carcinoma or cirrhosis-related death, both attributed to hepatitis B and hepatitis C. I'm sure you would note, if you do that, it's much more higher for hepatitis B across most of our countries. There is also differing opinions on hepatitis B, which are based on treatment criteria, when to start treatment, and also for vaccination of high-risk groups. There is vaccination that has been accepted for medical providers, including nurses and other sanitary workers working on healthcare facilities. But for high-risk groups, which are people who inject drugs, sex workers, MSM, transgender community, there has been not an agreement on whether to vaccinate those groups or not. US CDC in April has started recommending universal vaccination of all adult groups starting from 18 to 59 years. That's a fairly recent recommendation in April, so WHO, when they update the guidelines, probably will look also at vaccination of these high-risk groups, which are all categorized in our national programs as high risk for hepatitis B. There is also limited civil society engagement. This is again specifically true for hepatitis B. We've seen a lot on hepatitis C, but hepatitis B, that has been fairly less. Now, This is my last slide and the concluding one. Specifically for hepatitis C, growth we have seen in terms of national efforts to screen and treat hepatitis C, and there is also an increasing political will, but there are very few large-scale programs that we could look at. There are different service delivery models that has been adopted by national programs, and also community-led and community-based programs are available, which could be adapted based on our context, and also scaled up to the extent that we would want. The prices for quality assured DAAs are low now, as I mentioned earlier, less than 100. Procurement mechanisms, as we have seen for Global Fund and other avenues of procurement, are all available to us to get these quality assured drugs. On hepatitis B, morbidity and mortality are concerned. 79% of death in our region, and 59% is very high. We have to think about addressing that. LMICs, low and middle income countries, are finding it difficult to follow the current recommendations. We would see a new one sometime in October, hopefully. But the simplification of recommendations of providing treatment to all with chronic infection would help reduce mortality. That's something for us to see. There are new data that are emerging, and thankfully many of those data are coming out from Asia-Pacific countries, including South Korea, Taiwan, China. When it comes to hepatitis B, the lack of political will and the lack of national program is very evident if we compare to hepatitis C. And with that, I wanted to pose this question. We have 8 years to achieve this elimination targets of reduction of 90% of new cases and 65% on mortality. And will we be able to achieve those targets if we go at this current pace, both for hepatitis B and also for hepatitis C? Thank you so much, and I'll be happy to take questions.
Thank you, Giten, for the fantastic presentation. We got a couple of minutes for questions, so if you have any questions, please come up to the microphone.
Sawadee Kap. Thank you for a brilliant presentation and the report. My name is Simon. I'm from Russia. And the question is about, for example, in our national vaccination calendar, we do vaccinate children from the beginning from hepatitis. And the question is, do you have programs in Thailand and in Asia region that deal with children? Because, of course, there are a big burden in a higher population and in adolescent, but one of the keys here is to begin to prevent as early as you can. Thank you.
Thanks so much for that. We do have most of the countries in the Asia-Pacific, bearing Nepal and Bangladesh, have birth dose vaccination and also the 3-dose vaccination or 2-dose, depending on the national guidelines after that. In fact, if we look at the WHO's indicators of 5 years, I think it's less than 2%. Yes, that has been already achieved in many of the countries in the region. And also globally, I think, because of that vaccination of birth dose vaccination, and also the 3-dose during at adolescent stage or children, yes, children, those are already achieved, I think. And we do provide those things. I think it's true for most of the countries. I'm aware that Nepal and Bangladesh don't have it, but others do have it, including Thailand.
Thank you very much. It looks like the only problem was the elder one. So one day we will solve it. Thank you.
Thank you.
Professor Parker.
Thank you. David Burker, Nijmegen, Netherlands. You presented the data on the prices for the cost for the DAA combination. So with a low cost for the soft duck, 12 weeks. And you also mentioned 8 weeks treatment of some of the other DAA combinations, but they are more expensive. Theoretically, I would also expect soft duck to work for 8 weeks, but there are no data, I think, about that. Are you aware of any studies looking at 8 weeks of soft duck? Because if that is the same success rate, that could further reduce the price.
Yeah, to my understanding, I don't know if others were aware, but to my understanding, 8 weeks, there was a problem with that because these 2 drugs came from 2 different companies, and there was issues around doing clinical trials together, and many of the things at the initial stage when a lot of clinical trials were being conducted, I think that was something which was dropped out because of issues. But to my knowledge, I think there are no large trials where 8 weeks on soft dark has been studied to a scale where it could actually be used as a recommendation.
Yes, we will take it as the last question. Thanks.
Good morning. I'm from Vietnam. So my question here is, we are concerned about reinfection hepatitis C among the people have been completed hepatitis C treatment. So could you say with us about the experience or any the study related about reinfection of the hepatitis C among the people have been completed hepatitis C treatment?
Yeah.
Thank you.
Thanks. I think there's quite a lot of study among people who inject drugs. Now, again, whether it is a reinfection or whether it is a relapse or treatment failure, that could only be understood if we have stored samples prior to that initial treatment and we do sequencing of the virus when that new infection happens. So there are studies that has happened among people who inject drugs in Australia with Dr. Greg Dorr and his team. They have done quite a lot on, but those are pretty much focused among people who inject drugs. Specifically, reinfection that they said was fairly low. If I recall correctly, it was lesser than 3%.
Okay, thank you.
Thanks.
Thank you, Giten. Thank you so much for the
Thank you.
presentation. Thank you.